Now I would like to call our another phenomenal speaker, Dr. Suneel Kumar, consultant physiotherapist, the National Health Services, United Kingdom, for a motivational session.
Honorable faculty members, dear Asif Sheikh, Dr. Rana Siddiqui, a great speaker and the teacher for me, and all of you, my colleagues, physios, today, tomorrow, future physios, clinicians, consultants, doctors, thank you for allowing me to be here today. I have not prepared myself today. Because it was such a short notice. So while I was trying to sleep in the train, which I couldn't, I wrote some mental notes. So I may not be very organized. But in a good way, you can stop me and ask me questions. I hope so. So that way we'll go. Tell you something about me. Last time I was here, I was working in UAE. Because I'll talk about the scope of physio, I might tell a little bit about my journey. Just a little hint. I am not the best physio because I'm learning. I want to be better, and as long as I have will to get better, that's the journey I always wanted to be. So last time I was here, I was working in UAE. I worked there for 6 years. I went there from UK as a senior physiotherapist in a department where it was just myself. They opened a new hospital. I was given to work 3 days a week. And we saw 2 patients every day, 1 reception. When I left after 5.5 years, I had 26 physios, 3 OTs, 3 speech. And I was promoted to be a manager, then to head of department, then head of business, then head of services. Talk about money, it's very important. So I used to earn for my department 20,000 dirhams. When I left, I used to make 1.7 million a month. So there's a lot of money in physiotherapy, so you should all be proud. And there's a lot of growth in profession, which I'll talk about as well. A little, just a comment on Dr. Rana Siddiqui's speech. She said, patient-centered care. And once I heard from one of the occupational therapists, it's not the person who is disabled, it's the environment which is disabled. I give you a simple example. If a patient has severe osteoarthritis, let's say it's a common thing in the knees, and he or she cannot do stairs, what would you do? She live in a house, this is typical like Western society example. She live in a house, she can't do stairs. Is she disabled? Yes, she can't sit in SUV. She can't get up on 4x4. She find it hard to sit on the low car. She find it hard to step up more than 12-inch step. So is she disabled? We can class her disabled, but the same person can live a mobility car where she get in and drive. Same person can live in a flat which is 1 level with the lift access, live as normal life as anybody else. So it's the environment which is disabled, it's not the person. Same goes for somebody with a spinal cord, whether it's a paraplegic patient. I have seen treated patient with paraplegia. They get in the car, get out of the car, get a self-propelling wheelchair, go out in the society, work as a teacher. He's a great fan of Harlequin rugby. If you know, that's a very famous club. He's a fully independent guy. Imagine he has no bowel and bladder control. He self-trained himself. You would not expect any care he would like. He's fully functional gentleman, and he was joining a wheelchair. I don't know whether it was rugby or something, but he was so active. We would be proud. I am not as active looking at more weight, but he was far more active. Somebody wheelchair bound for life. So imagine, guys, the amount of the difference that you can make in somebody's life is enormous. That another quote I'm going to take home today. They are differently able. Just another touch on Madam Rana's speech. you talk about privacy and dignity. I was done once for not maintaining privacy. So behind the cubicle, there was I worked in a unit which was like a multidisciplinary unit led by a consultant. So the patient comes to you, elderly patient, and they would do assessment by a nurse, a physio, uh, then by the consultant, whoever is the lead. And while the nurse was doing assessment, they were in the cubicle. I was outside while I wanted to get in. Most of the family, our social history is the same. So I was outside just listening, social history. I thought I have to repeat again, so I better be there. So I just heard for 2 minutes, and when they finished, I went in. I said, "Madam, I just heard that you live independently and you can manage and you can drive yourself." She says, "How do you know?" I said, "I was just outside while I was coming in. I thought I would just save me time." He says, "Do you know, legally, you're not supposed to listen to that conversation. That's a personal information. You're abiding by the law. You broke a rule." I just took a step back. I said, I'm very, very sorry." She said, "No, it's not. Sorry is not enough." This happened with me. And I say, my sincere apologies. This is definitely a mistake because a curtain is as good as a room, as a wall. And I should not be listening to that. I'm very sorry. And I have to write an apology to her. My department gave me a warning in writing. And then, if anybody knows CSP, Chartered Society of Physiotherapy, so there's a health professional council, HCPC, and there's a governing body, CSP. Um, there's a consent document, which is 200 pages, consent document. I have to read the whole consent document, and I have to prove that I have read and I understand what consent means before they take my warning off. This is how important consent is. This is how important privacy and dignity is. Yeah, talk about Dr. Sikandar's speech. He was talking about a lot of research. So, I'm not good at research at all. And while in the private clinic that I work, we just bought a shockwave machine. It gives a lot of money, because normal session we charge is £55 for half an hour. A new patient £70. But with the shockwave, one session £95. Okay, good investment. Paid 20,000 pounds. And the guy who sold it guessed, because I'm talking about scope of physio and research at the same time, he told us it's good for patellar tendonitis, and he threw 20 papers in front of us. It's good for calcification here. Wonderful. It's good for Achilles tendonitis. Brilliant. But not on terminal tendonitis, not on terminal tear. But it's good for hamstring. But don't use it. So why? Bupa will not pay you. So why? It's good. It's good. We treat it. We get results. But it's not research proven. So I'm telling you how research important is. How important it is. Yeah? So they say, we'll not pay you, so only use it where there is a clinical significant difference proved by the papers, meta-analysis, random controlled trials. So we only use for 3 conditions, otherwise we will not get paid. So same goes again. People who treat a lot of frozen shoulder, that's a common from the day I qualified. We all say frozen shoulder. Any shoulder can't move, it's a frozen shoulder, right? And then we learn, no, it's not frozen shoulder, it's different. It's the capsulitis and adhesive capsulitis. And then there comes something hydrodilatation, they inject and the physio move. Then you do MUA, all these things. So I used to treat these frozen shoulders. Then I learned, okay, it's not frozen shoulder. But if it is true adhesive capsulitis, you don't do anything. You see that patient once, you give them exercise. It will take 12 to 18 months. As per research, patient will get better. If not, then you do MUA or injection first. So there's a protocol, right? Here, how many sessions I could do for capsulitis? I don't know, 20, 30, 50, 100. As long as it's coming, I'm treating. But I'm saying to you, the research is so important. You will be rewarded by the treatment. by the knowledge and by the result. It's really, really important. A lot of colleagues, especially students, ask me, so many physios, so many colleges in Pakistan, do we need them? So many physios. हर जगह पे फिजियो आ रहे हैं, होगा क्या? हमें जॉब नहीं मिल रही, बाहर जाना है, सबको सेटल होना है, होगा क्या? We have so many physios. Do you know how many physios are there in the UK? Guess. Can you guess? 64,000 physios. 64,000 physios are registered with HCPC. UK has registered maybe 1%, 0.5% living abroad, not practicing. 0.5% or 1% must have retired, I don't know. But or maybe there are some overseas not practicing. But I'm sure 50,000 physios are practicing in the UK. What is their population and what is Pakistan's population? And I'm talking about only physios. There are so many other professions like physio, which I'm going to talk about now. सबके पास job है, सब settles हैं. How? Right. When we grow the number of physios, there will be a saturation. The saturation will drive competition. There will be fields, work that you will create. There will be clinics. There will be jobs in the government. It will all happen. You will work harder to land a job. You might have to work 6 months volunteer internship before you get a job. These are not bad things. These are good things. You will all get a job. You will all settle. Because 64,000 physios settle in a country which is what? 1/10 of Pakistan? So I'll talk about few. What is the scope of physio in the UK? So in UK, we have just physio who is qualified as a newly qualified, newly grad junior physio. Then they become senior physio. Now they can choose to become a sports physio, a pitch side physio, which we have we all know Pakistan cricket team has physios, and now the under 18 team has a physio, which there was none before. Well, there have been for a while. Very soon there'll be a physio with every football team, a hockey team, then there'll be under 18 hockey team. So there is so much out there. With the social media, every sport is becoming more popular. It is getting more accepted, and there is a money in it, and there is a media in it. They all need physio. They all need physical trainer, coaches, psychologists. The whole world of sports is there with health professionals along with it. So there's so much demand in that one particular area, which is literally empty, just empty. We just have physio for cricket. That's all we know. That's all I know. Moving on, we have manual therapists. We have neurophysios. Now, because I was a neurophysio, I was trained as a neurophysio. Then I had to work in, we call it ICU, but the ICU for stroke is called HASU. Then I have to work in HASU. Then I worked 6 years for stroke. Then said, no, you are a stroke physio. You can treat a stroke patient with upper limb weakness, spasticity, something along those lines. I'm talking about all the different lines of physios that you can get into. We have a women health physio. We have a presenter today. There's a lot of scope about that. We have a vascular physiotherapist. Has anybody heard about vascular physio? Yeah? So we have vascular, and the vascular physio they only do vascular therapy. In UAE, I had a vascular physio full-time, just vascular physio. We have so much work for one vascular physio. We have oncology physio. Have you heard about that? Cancer physio? Oncology physio? There we go. We have ICU physio. We all know that. We have a chest physio. We all know that. We have a cardiac physio. We all know that. We have the elderly care. We have a falls and balance. We have intermediate care physio. We have a long-term care physio. Home-based, you all know. I was recently offered a discharge coordinator job, and that is becoming more common because physios are the gatekeepers. They can get patient in and they can get patient out quickly. We move patient, and once this documentation that Dr. Rana Siddiqui was talking about, when you write these outcome measures, that patient is able to walk from A to B, can do 2 steps of stairs, needs to be discharged. It will be outcome measure driven. I will change a little bit. So how long it takes for a TKR, because in Pakistan everybody knows what is TKR and THR, right? Right, okay. When patient discharge after THR, total hip replacement, when does patient discharge? How many days? How many days? 4 days? 3 to 5 days? 3 to 5 days. Okay. Now, 5 days was 10 years back. 3 days was 5 years back. Now we have enhanced recovery program. Day 1, total hip replacement, as long as cemented, go home. Same day, go home. As long as you can weight bear, you can't do any harm, you follow some precautions. If cemented, don't even follow precautions. If non-cemented, yeah, don't do twist, turn more than 90, bend down, you know all of that, right? Same day discharge patient, what does that do? It saves the money. Everything rolls around money. Patient stays in the hospital, they get infection, they get secondary problem, they get bed sore, other problems, right? So now the enhanced recovery program, patient gets home quicker. What does that create? Work for community physios, work for carers, work for community services. TKR, 2 days, out, right? As long as they can achieve 90 degree, extension, flexion to aa jayegi, baithega, flexion aayegi. As long as they achieve 0, no problem. Day 1 discharge. They take 2 days at least TKR. Okay, now we landing this. Okay, if it is a private hospital, the package pays for 3 to 5 days. The patient can choose to stay in the private hospital, and they do, because nice food, physio comes twice a day. If they are in government hospital, out second day, out first day. It's one bed, it's a cubicle, food is okay, nurse will not help you. They will say, okay, you need to get up yourself. In private, they will say, sir, I can help you. So it's a little different, but end of the day, it's changing now. So NHS give bulk contracts to private hospital to do total hip, total knee. So a patient can choose to go NHS or private, which does mean the standard of care should match. There should not be any discrepancy between the standard of care in NHS versus private in an ideal world. So we're moving on. We were talking about the different work of physio. This long-term care physio. Has anybody heard about craniosacral therapy? You heard about craniosacral therapy? I don't know what they do, but there is a physiotherapy there. They do that. One of my colleagues and I still pull her leg, and there's a lot of work for research physio. A lot of work of research physio. I always say it's boring, but I'm sure once you do it, it's such a rewarding job. Peds, we all know, peds physio for adult and kids. New job landed called safeguarding physio. Do you know what safeguarding physio? They work in safety. There's a whole line of social services, and somebody has some line of abuse, whether it's social, physical, psychological. There's a whole work of physio along those lines. Dr. Rana is a physio by profession, right? What is she working? WL2, charitable sector, developing services, improving services. There's lots and lots of work. There are so many physios can extend to. Now I'm going to talk to you about the juicy part. Right. Now, in UK, what they've done, 10 years, no, 20 years back, they said they have extended scope physiotherapy. A physiotherapist who perform outside the scope of their practice. Extended scope physio. So they can do injection, they can prescribe medicine, and they can order x-rays, MRIs. Okay, that was the concept for last 20 years in the UK. So like handful, I would say maybe 0.5% of the physio get up to work to become extended school because it's quite intensive work, right? Then what happened? In last 5 years, government thought, wow, physios are best at diagnosing. They can inject, so why do I have to pay an orthopedic salary? Let's pay physio a higher salary. They're already doing injections. They can treat any MSK patient. And now they are prescribers as well. So they created a new thing such as called first contact physiotherapist. First contact physiotherapist says a lot itself. You are the first contact. Patient doesn't see their primary physician. They come straight to you as long as they have an MSK problem. To be an first contact physio, you should be able to diagnose that patient within 15 minutes. Prerequisite to be a first contact physio. 15 minutes, the moment patient in, you should do diagnosis. You should be able to screen it. You should be able to know, is it the right patient for you? Does it need to be referred to someone else? If you need investigation, can you do it? Out. Can you refer it to physio? Yes, do it. That is saving a lot of money to NHS. And now everybody wants to become a first contact physio. It's a well-paid job, and it is a lot of skilled. Are you all with me on first contact physio? This is like a primary physician job. Yeah, because I'm just a physio. I don't do research. Well, I hear about research. So all I'm interested is seeing patient, how quickly I can treat the patient in the best way to make this, right? My heart and everything goes towards treating the patient best possible way, as many skills I can get. Coming to the bottom line of it, there are so many line of work physios can do, and that will all come here. This field will mature even in Pakistan. We talk about tools of your trade. So what do we have as a physio? We all talk about hands. Khan Sahab always say we have hands. These are tools of our trade, best tools of our trade. We are somehow disadvantaged by this word massage, right? We are not massage therapists, right? If you are able to touch patient, you hold that patient, you press that patient, you move that patient, you move a specific muscle, you do ischemic contraction, you do soft tissue release, you do myofascial release. And if you do it for a reason that you have, if there's a clinical reason behind it, do I care if somebody says the massage? I know what I am doing. I can make a difference. Do I care? Should you all be care about somebody says you're a massage therapist? I give a damn about it. I know how to treat the patient. I provide the best care. Then we have all these machines which sell very well, TENS, ultrasound. Now we have laser, we have shockwave therapy, we have TICAR therapy, we have robotic therapy. Right? I've just named one more profession for you. The guy who sells us the robotic therapy is a physiotherapist. The guy who sells us ultrasound is a physiotherapist. The guy who sells us TICAR therapy is a physiotherapist. So there's so much job in marketing for selling physiotherapy equipments, right? When I was in Karachi, we used to have Anasco. There's one big shop 20 years back, Anasco. It's still there. So now these equipment should go out and about everywhere, sold by physios. So that's another line of work. We talk a bit about the assessment skills. We need to have a robust skills. I believe one of the most important job of the physiotherapy is not just assessment and treatment. You also need to screen the patient, screen for red flags. Right? Patient comes to a doctor to say, I have a pain in the chest and I'm coughing. If it is UK, doctor will say, yeah, it's a cough. I listen to your chest. Bit of a wheeze, should get better. Use some home remedy. right? If it is UAE or Saudi Arabia, bundle of antibiotics, lots of anti-cough, and lots of things. If it comes to the physio, they will ensure if it is if it is a wheeze, is a rider, whatever noise is that, what can we do about it? Breathing exercise like this. If it's a patient with the back pain, is it mechanical back pain? Right? Is it a fall, trip? Is it a chronic back pain? Is it a discogial pain? Is it a referred pain? Is it a sciatic pain? Is it just nerve tension? Or is it a quadricular or spinal cord patient? If it is quadricular spinal cord, you send it straight to A&E. Screening is so important in the profession now, right? You don't always have to treat patient. Your assessment is paid enough. You got paid for assessing patient. If you assess that patient, treatment is easier because you know what to treat. The protocols are there. I'm going to talk about how do we improve our skills. And some of this goes with me, what I have learned over time and how I have learned. I have failed, I have tried, I have failed. Something called peer review. You all know what is peer review is? So a peer could be your senior, a peer mainly your colleague, if you're a student, your friend, your classmate, your groupmate. So you need to review your colleague's assessment. Ask your colleague, can he do or can she write few lines about how do I treat in terms of my assessment skills. So allow them, treat one patient, let them stand next to you for 20 minutes or 15 minutes. Don't let them talk. Take the permission from the patient. Let them write how do they feel, not feel, what would they say about your assessment? So if I treated a back pain, did I do full assessment? Did I bend myself too far to assess? Did I miss the SLR test? Did I do slum test? Did I check the fragility fracture depending on the age? Did I do all the subjective, objective, all the assessment? And they might say, actually, you could have done this. You could have done this. And you do the same critique for your colleague. Two of you together, do an assessment for the same patient. Take permission. Can we both see you together? Take a stroke patient, take a nice patient, do a simple patient, do a difficult patient. And then you talk to each other and do write your SOAP notes and then go back and check. Do you write your SOAP notes? Do you write goals for the patient? Do you write problems-oriented medical record system? Do you write patient problems? And your hypothesis, what do you think it would be? What would you do to change it with the time? And that's what we call SMART goals. I'm sure you all know what SMART goals is. We talked about that last time. Yeah? It's really important. Keep record of it. You'll be proud when you see it after a few years. I was there, now I am here, and I feel better. Reflective practice is again something similar. There's a reflective log. It's kind of CME that you can maintain yourself. You can present towards the professional body as well. So you have this reflective practice. I saw this patient, Mr. So-and-so, with a back pain or shoulder pain. What did I do? Which outcome measures did I do? How do I treat it? Did I follow the SMART goals? And then what would you do differently next time? Did I miss anything? How would I treat it differently? What if I have a same patient of a different age, take different variations? I can give you a reflection log papers also. Evidence practice, you all know evidence practice by now. Practice driven by the evidence that you have. Whatever you're doing should have some backup of the research, some journals, some papers. As I know, you're all doing wonderful poster presentation today. So I am hoping that I will see some of your references on those posters. So whatever you're claiming to achieve or have read or writing there, they should have some reference to it, right? So that would be great to see that. That's the first line of research. Another important point, do not hesitate to refer your patient to others. It needs a lot of guts, at least for me. I give you a little simple example. In the private practice, I saw somebody, 17 years old boy, come on Monday morning, say on Saturday night, he was out and about with the friends. He thinks he fallen down backwards. He woke up Sunday morning, so much pain in his back, he can hardly breathe. It's a thoracic pain. And he came, because he had a private insurance, he came straight to a physio. He doesn't have to see GP. It was not the case of going to emergency. So he came to me. I'm talking a bit. I'll take one more minute. So I saw palpation-wise, there was a lot of tenderness on T67. He has a pain on coughing. He can't turn on driving. He can't sleep. He can work, he can walk, he can sit, he can do normal living life. But he has a sharp pain on VASI scale of 7 to 8. He has sharp pain on coughing, and it's acute injury more than 48 hours. What would I do being a physio? Sorry, I've just given a case. So this 17-year-old gentleman who fallen on Saturday night, coming home after a couple of drinks, he wakes up on Sunday morning with severe sharp pain, mid-thoracic region, T67. He comes to me on Monday morning, say, I have sharp pain, and there's tenderness on T67. I can move it with pain. I don't see any other inflammatory signs. Afebrile, obviously. Pain 7 to 8 on movement, resting, no pain. Can't turn, twist while driving. Other things are okay. What do I do? Investigation, perfect. It took me 10 minutes to decide because of private practice, right? I have a vestige interest. I've been given 5 sessions. And if I send him back for some investigation, I lose 4 sessions, right? I said, no, I need to send it. It's fair. He will, exactly, thank you, you answered already. So he will come back to me. So I said, okay, go straight to A&E or go to your GP. I need a chest x-ray. Now, he said, okay, can you write me a letter? Okay, I'll write a letter. Once you start writing, it becomes so easier. It takes guts to start writing. So very quickly wrote a letter, gave it to him in hand, go to your doctor, have a chest x-ray. He came to me after 3 days, my chest x-ray is clear, I started treating him. So the bottom line is, the physio profession is very, very rewarding. It has so many lines of work to achieve. So be proud of yourself, everybody.